Nice to meet you, dear judges, professors. My name is Avi. I'm an oral surgeon. I'm based in Klaipėda, Lithuania, and I have hopefully an interesting presentation to share with you guys. So the topic for today is following the KISS principle. If you don't know what it is, it means keep it simple. Some people say smart. I like to be a little bit more humble and call it simple and stupid. So it's a simplified and predictable technique for sinus floor elevation with soft tissue correction. And I call it auto-identification, the one birth protocol. So let's just jump in. Okay, so yeah, working day. This is what I just finished a few minutes ago. This is how my weekend went with my daughter, Gabriela. And now let's jump right in. So we have a male patient. He's in his early 40s. He's healthy. I lost his tooth 26 about 10 years ago. He wants to restore it, restore the defect with the dental implant. So we have the clinical view. We have a little bit of some root that was left here for I don't know how long. And this is the CBCT that I will talk a little bit more seriously in 1 second. The problem that we are dealing with is, of course, we have the sinus pneumatization. We have a sloped sinus floor varies from about 1.7 to 2.7 millimeter of crestal bone that's currently available. We have a soft tissue defect due to the buccal collapse, as we all know, that happens after tooth extraction. So here we can see the buccal collapse. And this is the CBCT. And if you don't mind, I would like just to take 1 moment to discuss it, because when I talk about this case, usually I see the difference between the, let's say, less experienced doctor and the more experienced doctor. So the less experienced doctor, they see this cross-section and it's okay, I go for a lateral approach, everything is good, we will make it and everything will be better. If we get into a little bit more detail, you know, we have a thick cortex here on the buccal, and look at this type of sloped anatomy. Now, as we know, one of the keys to success for proper lateral approach sinus lift is to properly release the Schneiderian membrane from the palatal wall. It's a must. Look at the sloping. I mean, is it doable? For sure, 100%. We can do it. But this is not an easy case. Also, don't forget, tooth 26, left-hand side of the patient. I'm personally working from the right-hand side. By all means, this is not such a simple lateral approach sinus elevation case. It is doable for sure. Now let's talk a little bit about our goal. So as little surgical intervention as possibly as we can. The surgical part must be done as atraumatically as possible. Okay, we like to talk about atraumatic surgery. What does that mean? We will discuss it in a minute or so. I would really like to address both hard and soft tissue defects during the same surgery, if possible. And of course, reducing the healing time to a minimum and doing the surgery safely, predictably, and as easy as possible. And these are the most important factors for me as a surgeon. So what are our options? So talking about the hard tissue defect, we can go for a lateral approach sinus elevation in a stage matter. So we do the lateral approach sinus lift. We wait from 6 to 8 months. We place the implant. We wait another 4 months, and then we go for the restoration. This is, let's say, the classical ITI guideline. Option B, we go for a lateral approach with simultaneously placing the implant. We wait 6 to 8 months, and then we go for the restoration. Or we can go for crestal sinus elevation using, we cannot go to crestal sinus elevation using Summers osteotomes. It is contraindicated due to the sloped sinus floor. So Summers is a complete contraindication for us, but we can also use Danceberg and go for crestal sinus elevation with simultaneous implant placement with a healing abutment, meaning we go for 1-stage approach, and 3 months after restoration. What about the soft tissues? So we can go for a CTG from a connective tissue graft from the palate. We can think about doing a free gingival graft from the palate. We can go for roll flap. And regarding the hard tissue defect, we chose the crustal sinus elevation using the Dunsaberg with simultaneous implant placement, with a healing abutment, with a one-stage approach, and 3 months after we go for the restoration. And for the soft tissue defect, we chose to go for a roll flap, and I will show you immediately what we mean. So let's go for the surgical photo. So we have the flap design. So as we can see, we do a papilla pairing modified. If you look for the literature, it will be called the modified Abramson roll flap design. We do not touch the papillas. We use the opportunity with a small excavator to remove this little root tip. Then we take a high-speed burr. We de-epithelize this area. You can see my mouth, right? Hello, anybody?
Yes, we can see the mouth,
okay. Thank you. It's so strange. Yeah, I don't even see myself. So your feedback is very valuable for me. Thank you, Professor. Okay, so we take a small diamond burr on a turbine. We do de-epithelialization of this area. And now the one burr protocol, what does it mean? Well, because we are very, very close to the sinus elevation, I don't want to risk perforating the sinus membrane. I'm just taking one burr, and this protocol is based on using the 4.3 millimeter Densa burr in correlation with the Eneridge 5 millimeter with either 3.8 or 4 millimeter core. This is the protocol. One burr, one implant. What do? So the first stage is we just use this burr in cutting mode, 150 RPM, and we just make a small notch just to make sure. As you can see in a minute, we just dig into the bone and we just make a tiny notch, not even a millimeter. The whole purpose of this is to make the bed. So when we go for the osteodensification mode, the drill doesn't start bouncing around. That's it. It takes about 10 seconds. And now we switch. We go for the osteodensification mode. This is a different case, but the principle is completely the same. We change to the RPM. We elevate the sinus. A lot of irrigation. We use sticky bone in this case, and again, standard osteodensification sinus elevation protocol, only that I'm using only one burr. So this is how the surgery itself looks. One of the, let's say, reasons that a lot of clinicians like to avoid crustal approaches visualization. This is what we are being taught in the maxillofacial department. The first rule of surgery: you don't see, you don't do. Well, this is the sinus floor. We can all see it quite well. This is the grafted sinus that we can all see quite well. Everything is very, very nicely visualized. Implant placement in the correct 3D position, super important. I do a little poncho with the healing abutment. I just place the PRS membrane. And now what I do is I fixate the roll flap with one horizontal suture. This is how it looks. I start from the buccal. I go back in from the palatal, and I make one knot. Then all we need to do is place 2 extra sutures, one mesially, one distally, and voila. Before and after. And now what I say to the patient, first of all, I hope that he will appreciate the hard work and the way that I avoided the lateral approach, because lateral approach we still do. I mean, it's not a religion. And it has its pluses, it has its minuses. Mostly the minuses are for the patient. The bigger the flap, we need to open, we need to make the vertical incision. And the whole healing problem that we're seeing from the patient's point of view is the soft tissue, is the large flap. This is where we start with the edema, with the swelling, and so on and so on. In some cases, we really cannot avoid it. But here, as you can see, this is truly minimal invasive. This is minimal invasive surgery that we are solving it with a small tiny flap that is fixed together with two sutures. This under any book is minimal invasive. This is right after the CBCT. As we can see, we have nice elevation and grafting of the entire area from the palate until the buccal. This is exactly this nice canopy that we want to see. And I say to the patient, come back in 3 months. Let's meet again. And we do a control x-ray. The minute that I don't see the sinus cortex, the old sinus cortex, shows me that we already have integration of the sinus, but it's not enough. I need to have an x-ray instrument to really measure it. So let's see, this is the clinical view. We have nice emergence profile. Okay, really nice actually. And what I do now is I take the additional instrument, I take the ISQ, and we measure the ISQ. Here you can also evaluate the nice emergence profile. So here we have about 75. We can go on with the prosto, and this is only 12 weeks after the surgery, 3 months. That's it. So we take the ISQ. I take an impression. The week after, the patient calls in sick. The week after that, I call in sick. Me, him, he cannot, we cannot. We meet again in 1 month. So 4 weeks after, and we just to feel safe, we retake the ISQ. And now look at the ISQ. Amazing. This is 70, 78, 80. This is really, really best case scenario. We give away monolithic zirconium crown. The subgingival is non-glazed. According to the zero bone loss concept, it's highly polished. Our technician really takes his time to polish it nicely. And we give away the crown. This is how it looks. This is before, after, and after. This is already, I am not sure if it's 9 or 10 months post-op after we gave away the crown, but I don't think it makes much difference. Let's say 9. So this is already almost more than a year after the first surgery. We have very, very nice stable bone everywhere. Nice corticalization. Sinus looks nice. Emergence profile looks nice. And now that we're revisiting our goals, yeah, so as little surgical intervention as possible, yeah, we did single stage sinus elevation with implant placement. It should be as atraumatically, well, yeah, we went for a crustal sinus for elevation. And as I showed you, the flap is so small. Really, the patient went to work the day after, said, doctor, I think you lied to me. You didn't do anything because I didn't feel any pain and I didn't feel any. He only took 1 tablet of ibuprofen of NSAID. I was able to address both hard and soft tissue defects at the same surgery. We did the sinus elevation together with the roll flap, and this is exactly what this protocol, the 1 burr protocol, is based on, fixing as many problems in 1 surgery. So we have 1 burr, 1 implant, the 4.3 Densa, the 5/10 megageneni ridge with a 3.8 or 4 millimeter core, and a roll flap. So these 3 factors will reduce the healing time really to a minimum, to 3 months after a patient came that is, according to everything, indicated for lateral approach sinus elevation. In 12 months, we were able to go from surgery to prosto. This is amazing numbers. And we did it, and this is super important, safely, predictably, by using my 1 burr protocol. Now, what the goal for today, what I want to say is that I'm a trained surgeon. I really like doing these big surgeries, that we start from nothing. We do a bone block, then we do a free gingival graft. From 0 to hero, we can call it. But whenever I do a surgery like this, that I know that I avoided a very traumatic surgery for the patient, this is what I'm really proud of. Not these big reconstructions, but these surgeries that instead of going for multiple surgeries, for doing very traumatic surgeries for the patient, left with 2 surgeries. Surgery that takes 35 minutes until the patient is leaving my chair. These are the really these look like small and easy cases, but these are the cases that I'm really proud of. So yeah, I want to thank you for your attention, and let's talk. Let's have a nice discussion.